Good evening, everybody, and welcome to the ESWT Academy latest webinar on shockwave technology and men's health. Really excited about this one and introducing Michael Strom, and also looking forward. We've had a huge sign up to this webinar and the upcoming webinars as well, which we'll touch on a bit later. Really looking forward to it. We want it to be an interactive webinar, so please contribute where you can. A little disclaimer, might have some contributions in the background from me. I've got my boy up at the moment, so hopefully it doesn't contribute too much. But otherwise, we will crack on. Like I said, the session is from the ESWT Academy, where we're here to push forward on the education side of things in the musculoskeletal injury. But today we're looking at men's health specifically. A lot of the feedback we've been getting is to have more informative and more information around shockwave for men's health, which is why we brought Michael Strom in. So the session is being recorded, so anybody watching back live, watching this session back, hi. If you do have any questions for those who are watching the recording, then you can submit them to info@physiequip.com. For those on the live session, the Q&A function at the bottom of your screen. If you're not familiar with Zoom by now, it's at the bottom of your screen. You'll see a little Q&A bubble there. Pop it in there and we'll get your questions answered. Other to that, I will hand over to Michael to introduce himself, go through your presentation, Michael, and then we'll get into the Q&A. Over to you.
Thank you. I'm Michael Strom. I'm from Copenhagen. I come from manual therapy, so a bit unorthodox compared to what I'm doing. For the last 6 years, I've been working in men's health. I've been working with Storz Medical previously. I now work with Wolf. I also work with MTS, so I am the shockwave guy. I do 95% of my work in men's health, so that is erectile dysfunction, Peyronie's disease, chronic pelvic pain, and incontinence. Before, I had a long career in the army. Today, all my life is shockwave. Last year, I presented in Colombia as a keynote speaker in urology for the Colombian ISMST, and also part of the chair moderator session in the urology ISMST in Amsterdam this year. So I have quite a lot of knowledge, and I'll try to just give you a very brief explanation on men's health and why we can use shockwave. So just sharpen your ears. This is going to be fast, and then we'll take the discussion in the end. This is my Copenhagen clinic. We have three main shockwave technologies. We have the electrohydraulic, the original, we have the electromagnetic, and then we have the piezoelectric. All is shockwave, all is a focused shockwave, but they're generated in different ways. Just remember that when you're reading the studies, all is a focused shockwave device. When we have the generation, we have a spark in the electrohydraulic device. In the electromagnetic, we have like a small fuse that generates the sound wave and focus it. And then with the piezo, we have these piezoelectric crystals that form the shockwave. And it's not to be mistaken as an ultrasound probe. It's not the same. So when we look at the way of generating the shockwave, we have a very, very high amount of pressure that's released in a very short time. Then there's a drop, there's a negative phase, and that is also where we find the intensity or pain that you can feel in a focused shockwave device. So just remember, very high amount of pressure in a very short time, that is defining a focused shockwave. So when we look at three different types of sound waves, we have the red one. That is an electrohydraulic shockwave. Compared to diagnostic ultrasound, you can see it's going up and down, very homogeneous. And then we have the radial pressure wave with a 3-bar input. So if you know about the difference, you know why we have different parameters. So remember, short time span, very steep increase in pressure. The radial is a bit more longitudinal, and the ultrasound is completely harmonious. So we don't have a sound wave there in that way, but we can generate it with the piezo. One thing that's really important for me to just put out there is we have two elements that have been used in shockwave for decades to explain why it works. We have the -60 dB zone, and that is where we have the maximum amount of pressure in the shockwave. That was what they used for the big devices for destroying kidney stones to define how much energy do we need to use to destroy that kidney stone. We still use that. And if we're talking about a condition as Peyronie's, we want to have maximum energy into a small area. Then we have the therapeutical effect. That is the 5 MPa. So this is a large area. So we have a focus part and we have a more general energy. So depending on device, they will mark either the very focal point or the bigger focal area where we have the main therapeutic source. Just remember, all of the devices has the same, it just come across in different ways. So minus 60B and 5 MPa, this is something we're gonna go even more into depth with when we do the physical course in Manchester in November. So if we look at this one, this is from a very skilled urologist, Hartman Post. He did a review of 350 patients that he'd been treating with different devices. He has all the major shockwave devices on the focus side in his clinic. Right now, this is an older study from 2020-21. He also now has a new BTL, so he's just adding to the equation. He's also been a part of the inspiration for me to do more than one device. So if we look at the minus 60B zone and the different range of energy manufacturers is advising for erectile dysfunction, then you can see a big difference. You just need to know there's a difference from device to device. And that's also the reason why the amount of pulses will differentiate. But if we look at the elevation picture wave, then this is a linear handpiece, the linear therapy source. So there's almost the same amount of energy in the minus 60B and the 5 MPa. So that is really good when we work with erectile dysfunction. If we want to go in other directions, we can look to where we get the most energy for the different types of devices. Some of these devices is not on the market anymore, but just be aware, you need to know what the device is so you can understand the study. This is the electrohydraulic. There's actually 3 different handpieces. I have 2 of them. I have the blue one and the yellow one. So I can define if I want to be more specific or more general. So do I want to have a very high energy in Peyronie's, or do I want to have a more soft approach, for instance, for erectile dysfunction or pelvic pain? You can also see here that we can actually see the size of the focal zone. So this is quite big for the yellow handpiece. We have different parameters for the energy. That will be common for all. But electrohydraulic, we normally see lower intensities compared to electromagnetic that we're going to cover now. This is electromagnetic, the highest normal standard source we have. That is by the Storz Medical. The one thing here is that we have 5 times 5 times 35 millimeter focal zone. That would be the same as this one from the piezo. So we can actually start to compare. They have 2 different handpieces, a standard one that can go to about 12 centimeter with the main part of the therapeutical effect, or they can have it more superficial to 1.5. Then they have another handpiece made for me, Peyronie's, or for diabetic ulcers. Higher energy, but lower penetration. So again, penetration, energy, everything matters. Then we have the last one, the one we're going to focus on right now, and also in November, the piezoelectric sound wave sources. So we have 5 different applicators. So you need to decide from the beginning what kind of effect you want in the tissue. Do you want to be superficial? Do you want to be more deep? Do you want something in between? Do you want the linear? All the different applicators has different energy ranges. You can also see the focal zone is different. So for me, my setup, my standard setup is the F10G4. I bought that very specific for Peyronie's because it has a very specific focal zone with a high energy. You can also use the G6 that I had in my hand just before. For the erectile dysfunction, I work with the linear probe. Then again, pelvic pain. Most people will go for the G10, but if we look at the anatomy of the pelvic floor, it's very rare that we need to go more than 4 to 6, 8 centimeters to reach the target of the muscles, but we're going to go through that in a bit. So the linear is quite unique. So we have a very specific focal zone that you can't compare to anything else. So we can use it to go very specific for the cavernosum. I also use it for the more fibrotic scar tissue cases of Peyronie's, where I want to have a large area. So some good options. You can just see it here. The difference between the linear and the focal point is a way of working. So we're going to work with that in November as well. So erectile dysfunction in less than 6 minutes. Some of the good things to keep and maintain a good erection through life is that we have exercise and physical activity. It's dependent on insulin, testosterone, normal weight, just like me, the nitric oxide, penile erection. So this is what we want to have people doing. And remember, we work with biological tissue with shockwave, so it doesn't matter that they don't want to change their lifestyle. So if they have obesity, inflammation, hypertension, metabolic syndrome, atherosclerosis, cardiovascular disease, neurology disorders, all these things will work against the erection. So when we have them in the first time, we need to define what is the root of the problem. When we know that, we can start working with shockwave. What we're aiming when we work with erectile dysfunction is the corpus cavernosum. That is the two big ones with the hole inside. That is the artery. The artery is about 1 millimeter in diameter, so it's very small and very sensitive to atherosclerosis. We have the dorsal vein. That is what you're going to block if you want to keep the blood in the system. That's also why we're going to advance on pelvic floor. We also have some nerves that's quite important. We have the pudendal nerve. That is the branch that's going to go to the penis, promoting the erection. That is coming from the sacral joints. So again, when you work with erectile dysfunction, think about the basics, the back, the nerve endings, and the nerve roots. So if we work with these things, we can actually do a quite good job for erectile dysfunction. This is a basic research study done by the Greek urology group. I've been having the pleasure of meeting those guys several times. And this is one of the best figures I've seen for years on how to tell about what shockwave can do. You have the energy put into the tissue, creates these microbubbles, the stress to the cell. It inflicts stimulation to the blood vessels, corpus cavernosum, interstitial tissue, and the nerves. So again, all the things we want to work with on erectile dysfunction. We have all the different parameters, all the biological effects that we cause by the shockwave. But again, it's about forming new blood vessels, rejuvenating the tissue, enhancing growth factors, stimulating the nerves so we have better control also for the pelvic floor. So if you want to read one study that really explains why we can use shockwave, then this is a study. It's also just been accepted in 2023 for the European Association of Urology that shockwave can be used for erectile dysfunction in vascular cases. When we look at the studies, I'm going to take some of the most difficult cases. This is after radical prostatectomy. So if we have a prostate surgery, there will be a nerve damage. In this review, they could see that the IIEF5 score, and that is the International Index of Erectile Function, is increasing. That means to get a better erection. EHS, erectile hardness score, increased significantly. That is also one of the determinants for if you can do the penetration. So we had a significant improvement with different types of shockwave. Another one, and I really like this one, low intensity shockwave for diabetic patients. These are some of the most difficult you can get. They have comorbidities. They are on different kinds of medication. Their lifestyle is not often that good. But with shockwave, and this is 12 treatments, this is done with an electrohydraulic device, so it's low intensity. They showed a significant increase in erectile function. The other thing they saw was that they could convert people that was not responding to PD5, that is the Viagra, the blue pill, to responding to it. So a lot of my clients is also coming in, been on Viagra for many years. They don't have the effect. Then I tell them, okay, you're not going to go to being like 18 again. But the first goal is to have you respond on the Viagra. So we can do that with shockwave. This study is also for radical prostatectomy. This is done by Igor Motil. He also works with the PizzaWave device. And it just shows that it's safe and we have a significant effect on the erectile function in the long run when we do the shockwave treatment right after the surgery. Another study, I presented this as a part of the European Association of Urology Shockwave Expert Group in January. A study that shows that not all protocols is the same. So this one is after radical prostatectomy, and they did 2 different protocols. one quite soon after the surgery, then one with a break, different intervals. The outcome is fantastic because it shows that after 12 months, then you have better effects with the shockwave compared to control. You can also see after 24 months that you have better effect compared to the PD5, the Viac group. And in the long run, you have a higher frequency of intercourse rate if you've been doing the shockwave from the beginning. So again, using shockwave as a part of the rehabilitation after surgery can give a big difference in life quality. And we also need to remember about the incontinence in these cases. And then one of the last one, I often get this question, can you use radial shockwave for erectile dysfunction? And we don't recommend it. No one in the urology world or people that work seriously with shockwave recommend the radial. This study is done with radial shockwave. They compare to physical training and then a combination group. If we look at the first 4 weeks, that is post 1, then you can see that the radial is having better effect than physical training. But we also know the blood vessel formation, the physical activity takes time to kick in. So after 3 months, you actually have better results on erectile function by exercising 3 times a week compared to doing a lot of session with radial. Of course, if you combine it, you're going to get some decent results. But again, radial compared to physical training, then just get your ass off the seat, do 3 times of exercise a week, and then you have a better erection than working with a radial device. We also have Danish studies confirming that. So we're going to move on to chronic pelvic pain syndrome. This is very complex. And this is also some of the cases where I can be struggling sometimes. So it's not about just having one device. These people will see you when they've been having pain for years. So they will have been going through the urology department. There will be mental components. Is it something about the organs? Are there any infections? What about the sensibilization of the nervous system? Are there still something firing from the head, the nerve roots to the organ, so they have the pain? Are there any sexual dysfunction that's combined with that? So this is complex. And this study just shows that if we want to work with CPPS in a good way, we need to be multimodal. So when you look at this very nice round one, then you can, of course, do the medication. A lot of my clients have been doing a lot of that. We can do bladder training, pelvic floor muscle training. We can do breathing. That's good to stimulate the nervous system. We don't want to go to surgery unless we have to. Then we can do myofascial therapy. So electrical muscle stimulation, biofeedback training. So we can also put in the shockwaves there. I see quite good results. Sometimes we need to keep it simple. So instead of starting to map something completely crazy out, then just look at the basic anatomy. So this is the anatomy of the pelvic floor for a male. We have the pudendal nerve going up to the penis. The branches is going towards the anus. So when people coming in and say, I have pain in the perineum, it goes to the anus. Okay, just think pudendal nerve. Again, look back to what I showed with erectile dysfunction. The sacral joints, the sacral part of the back, that is where the nerve is coming from. We need to stimulate that as well. So just try to keep it more simple because the urologists, a lot of doctors, they will do a lot of different things instead of just looking at the nerves. That is where we have the pain. So this study shows that we can have a significant effect in reduction of pain with shockwave compared to control. Anyone that works with shockwave already now know it. We know that we can modulate pain. So no matter what some specific studies shows, we know that we have the ability to inhibit pain hormones and signal pathways in the human body and for animals as well. This is also a very nice one that shows the difference between 6 and 12 treatments. And it claims that there's no difference. The thing that's being left out here is that we also have a mental component when we have dealing with pelvic pain for a long time. So we know that the main effect on the pain reduction will be around 5 to 7 weeks. But if the pain is not really gone, we need to talk with the patient about if we want to continue the treatment, accepting that the progression will be less, but they get the psychology support from you that's been working with them for a while. So that is something we always need to consider. And it's always debated, but we take care of these people. They really deserve it. Currently, I have a very complex case with a persistent genital arousal disorder. So it's like female having an orgasm all the time. It's painful, and in the worst cases, it can lead to suicide. On the hospital, they can't help anymore. We've been having some relief on the symptoms with the shockwave on the pudendal nerve, but we're also stimulating the nervous system with EMCT, NISA neuromodulation. So just remember, one thing is not enough here. You need to think out of the box. If you don't have the capacity yourself, be sure to partner up with someone around you that can help you take care of these patients in a good way. And just this very nice study is showing that this is about musculoskeletal trigger points. A lot of the things in the pelvic floor is trigger points. So we have the nerves and we have muscles. So don't make it too complex. Palpate, do ultrasound, but palpate with the device, see where do they have the pain spots, work on the pain spots until it go away. Then next time we do something else, see where do we have pain. It will move around. So just think musculoskeletal when you do pelvic pain. So we're going to go to Peyronie's disease. This is also very complex if you don't do it right from the beginning. So if we look on how it comes, I had a guy coming in today. His penis has been going towards the left the entire life. And then in January, he had something going on, and then it bended a bit more. So his first question was, how did I get it? I asked about Dutretens disease, the knuckle pads. That is a genetic disease in the connective tissue, which also often carries Peyronie's disease on the male side in the family. It can also be cause of smoking, trauma, alcohol. The guy wasn't smoking, wasn't drinking. There hadn't been any obvious trauma. So I said, most likely due to genetics, but also diabetes, hypertension, obesity, aging, testosterone. Low testosterone is also being coupled with having the increased risk of Peyronie's. So we need to define that. Most people will have it due to some lifestyle disease or trauma. Been hearing some very interesting cases during the last few years. I'm going to share some of them when we do the workshop in November. It's quite mind-blowing sometimes. What is really important is that we start within the quickest time from the initial symptoms. We have the best effect within the first 15 months. And this is because this is the formation of fibroblast. We have the transgrowth factor beta 1. That is one of the main inflammatory modulators for Peyronie's disease. We know we can inhibit it with the shockwave. So again, we can get them after 3-4 weeks, right when they get the symptoms, then we can do something. We can also reduce the pain. Had a guy coming last week, been having the problem for about 2 years. Then it's been starting to increase. Had him today, an hour ago. He could already feel less pain compared to what he's been experiencing the last many months after one session. So we know we can modulate pain. This is just a few images from the clinic, just to show you that it's not always just one plaque. So in the top right corner, we have the connective tissue, the tunica that's swollen, calcified. We have different pieces of plaque in the other side. And I think I have the first 50, 100 pictures that's different. So it's not enough just to feel. You need to do the ultrasound scan. That is also something we're going to go through in November. One thing that we need to be aware of is, again, diabetes. Diabetes is the buzzword right now in the Western world. We're getting obese. Diabetes is increasing. Novo Nordisk in Denmark is making a lot of money. We're quite happy with that. But if you have early onset diabetes and it's not under control, you have a higher risk of developing the heart plaque and bigger plaques compared to if you're more healthy. So again, we need to modify the lifestyle. This one is just to show you that we don't have that much research so far on Peyronie's. It's getting there. But a lot of the protocols is underpowered. It's with too low intensity, So the expert group we have in Europe with key opinions in shockwave urologists, we're all discussing high intensity. That's why we're looking into new options. So with this one, 2,000-3,000 pulses, 4 to 6 sessions, that's not going to cut it if you have these complex cases, and especially not if they have a lot of plaque. This one is quite interesting because it says that it can't improve curvature or pain. We know that it can work with the pain. So again, what is the parameters of the treatment? How many pieces of plaque? Nothing of that is shared, but we know we can reduce the pain. I can also find studies that say we can't reduce plaque size. In the end, it's all about working with elasticity. The last study here is from Denmark, and this is just to show you that, again, we need to work a bit more multimodal. So this is a penis pump. We use it for exercise for these guys with Veronis. Lars Lund, the Danish urologist that do most of the research in Denmark, he set up a study where he compared shockwave and shockwave plus the penis pump. And you can see there's about 12 degrees between the two groups. So if you do the pump, you gotta get a better result. So it's about pumping, so you get an erection. Then you're gonna work with bending, you're gonna work with stretching. Again, we have some tissue that is not flexible. We want it to be flexible. We want to think like scar tissue after surgery. We need to work with it to make it flexible and heal good. So we're just gonna look at this shockwave plus exercises plus lifestyle plus coenzyme 10. It could be vitamin E, tadalafil. It's not just one solution. So even though we have all these very nice devices, you still need to have your clinical reasoning. You still need to do a proper examination. Otherwise, you're going to fail. And that is where it really hurts me, because a lot of people, they want to make the money, but they don't want to buy a big ass expensive device where they can actually see what they're doing. So if you want to work with erectile dysfunction, that's quite easy. Pelvic pain, quite easy if you have your hands. Peyronie's disease, you need to have an ultrasound, because otherwise you have no clue about what's going on. So my thoughts is for this, that it's a very powerful way of working. Shockwave has some really good options if they're in the right hand. It doesn't matter if you're a manual therapist or a doctor, if you understand the technology, if you know how to read the study, if you can communicate with people, and you can also talk about the more difficult things, then you can have really good success in this line of work. But you need to have the respect. You need to really dive deep into the research, not just about the shockwave for the condition, but you need to know the underlying reasons. If you know that, then you can set some quite powerful treatment courses where you're going to have the most happy clients you can imagine. One thing is that you have someone that's able to run again, but someone that doesn't have pain in the penis or is not having problem with incontinence. That is something that really affects the quality of life. So now we're ready for questions, and I think I'm like 1 minute ahead of time. Just gonna stop the screen share.
Yeah, you're not done too bad there on timing. Not done too bad at all. No, really interesting. I know you crammed in quite a lot of information there into the half an hour, and I know I think you've given us quite a good insight into it's a little bit more than just pointing and shooting a shockwave machine at somebody's penis and magically it's going to start working again. There's a little bit more to it than that. I mean, for the people that are on the live webinar right now, this is your time to contribute. So if you have any comments that you'd like to make, any of your own personal experiences that you'd like to put in, as in with patients. I mean, if you've got personal experience with it yourself, I mean, feel free to throw that in. If you've got any particular questions, if you can please type it into the Q&A function at the bottom, and I shall ask Michael on your behalf to give the answer. Michael, just before, whilst people are sort of typing things down or popping things in the chat or the Q&A with any particular comments, like I say, I just touched on there, it's like it seems a little bit more than just a point and shoot aspect. right?
Yeah.
And I know you have worked kind of quite closely with industry, and some of the companies as well. And I think that's obviously really important from your perspective, is to work quite closely with industry, in that aspect. What's been like the biggest challenge, and what is the biggest challenge that people would face introducing something like shockwave therapy, or even starting a men's health, pelvic health service from your perspective?
I think the biggest problem is this one: grabbing another man's penis or another person's penis.
Right.
Yeah.
Yeah.
When I do my courses, I have lots of people that haven't touched shockwave before. They just see the financial purpose. So I normally have like 10, 15 slides where I just gonna get them away. So I have all crazy pictures with different erotic content, just to make them think about it. I talk with them about how is their own sex life. Can they actually talk about that part? Because if you can't talk about sexuality or the problems, then it's really difficult to understand the client. And the client wants to feel safe and heard. And if you're just sitting like this, uptight and like looking at them, then they're not gonna open up. So it's really about having the empathy for this, and you need to have the desire to work with this area, because people will see
Yeah.
through you. You don't have a
Yeah.
genuine interest beside the money.
And I suppose that's something that we've seen as well, and as one of the things that has come up in terms of like the education to provide, because it's like you said, there's a lot more going on, from what you're saying from a nerve perspective, and a few other bits as well that's happening. I mean, we've
Of
got a
course,
few pre-submitted questions. Like, oh, go on, jump in.
we need to have, this is on my own, but I would claim that 90% of people treating erectile dysfunction, Peyronie's pelvic pain in the world is not a urologist or doctor. It's a physio, it's a manual therapist, it's a chiro. There's no official education in this area. I even been at a hospital in Sweden where I was doing some shockwave training at an earlier point. Then I said, don't you do the vascular assessment of the penis before you do the treatment? No, they didn't really know how to do that. They did the prostate scan. So I made a deal with this urologist, say, okay, I'm going to teach you how to do the ultrasound of the penis, the evaluation on these things, and you show me how to do the prostate scan. So we had a very good day a few months later. So this is really experience-based. You really need to look into the studies. You need to read a lot of studies, follow the International Society of Sexual Medicine, be a member there, go to these conferences, because there's no formal education unless you're a urologist, and they just look at, most of them, for the PD5.
Right. And I suppose that kind of jumps into a couple of the pre-submitted questions that we've had, which is, what qualifications do you need to be able to deliver shockwave therapy in men's health? And before you jump in, I've been doing a little bit of research on this myself, because obviously from Physiocrip Academy's perspective, we want to actually look at what provision should be available and what the standard needs to be. And as if you're a physiotherapist coming out from a physiotherapy perspective, your degree does cover it, in terms of it does cover pelvic health, as far as I'm aware. There are PG certs available from some universities, so it's advised if you can go down that route, then you get yourself covered. Michael, from your kind of side of things, are there any particular? I know you've got your course as well. I presume that because of the lack of education, that's one of the reasons why you set up your course. I mean, in terms of your background, like, how do you make sure that you're covered and practicing safely?
Yeah, and it's different from country to country. We're not regulated in that way, so I can do it. I know that most of the people doing in Denmark, physios, chiros, and manual therapists, actually the ones that has the best result is the manual, because they really go into it. So you need to look on your scope of practice, what's allowed. I've been working a lot in the States. They have completely different rules. South America, only doctors, but they have the physios doing it. They just have the doctors to prescribe. So it's more about knowing the technology, and if you can get the hand on a focused device, then you're allowed to use it. But there will always be the thing that the doctor's looking down on the chiros are looking down on the physios are looking down on the manual, instead of just working together, because we all bring different perspectives into the pile.
Yeah, absolutely. And actually, the point that you bring up there is leading us into the next question, which I'm just going to get out of the way because we had, I think it was like 5 or 6 people had asked this question. Is which, here we go, which is the best machine for men's health? And that is the most popular question. So go for it.
And I'm not gonna answer that. I will say
Very
that
diplomatic.
I can see I know some of the people on the list. It depends on what you want to achieve. You need to look into the -60B or the 5 MPa. What is the main objective? Do you want to work mostly with erectile dysfunction? Maybe the 5 MPa is the most important. If you want to work with the Peyronie's disease, maybe you're going to have another device. Peyronie's disease is one of the reasons why I decided to go in another direction and having more than one device, because there's so many different kinds of plaque that for some, I just want to work with the linear so I can hit a large area if it's like a long calcified plaque, but there's not a hard density. If I have a more specific plaque, like the one you can see in the background here, actually this is about 1 centimeter. Then I want to have a focal point with a high intensity. So I basically bought my pizza wave for working with Peyronie's. The other devices, I am really happy with the electrohydraulic for erectile dysfunction. It works fantastic. And then I also have a wide focal zone with lots of energy that can go deep. So it's really about how specific do you want to be, how skilled are you with ultrasound, because that is Peyronie's, that is ultrasound and specificity. Erectile dysfunction, pelvic pain, more general, then we can work with all the devices. The other devices can also do really good for Peyronie's, pelvic pain. So it's about what you want to work with, what kind of concept. But again, I use all the free devices on a daily basis. And sometimes the new protocol is that for Peyronie's disease, I will combine these two, the piezo for this very specific, and then I would use the MTS, the electrohydraulic, to work more general, to have a wider simulation of all the other biological factors with a lower intensity. So again, you just need to buy one of each.
If you've got the money, get them all. But I suppose to sum up on that as well, it's like obviously not everybody's going to be able to get all the different bits of equipment like yourself, and it's I suppose as well it's if you've already got a focus shockwave available and you're looking at opening up a men's health clinic, it's really understanding that -60 dB zone, that 5 megapascal zone, really understand the technical outputs of your machine and then what that is best used for. And I suppose as well, I think at this point, if you don't mind me kind of going out on a limb here, is that if anybody has got a device that they've already got, is that we've obviously got the course on the 15th, which we'll touch on a bit later, but they can reach out to you, Michael, and ask your advice, because I know you know the systems pretty well, of like what's best applied for that technology.
I'm the honest answer, regardless who I'm working with. I'm working with 2 of the companies right now out of the 3 biggest in the world. But yeah, I have all the devices, so I'm getting some experience. I'm tracking data right now. So hopefully at ESWT next year, I can present something that will show some comparison between the devices. But it's really interesting because we can have effect with everything. I will say 80% of your indications you can do with each of the device. It's just when you are aiming for the last 5-10%, you're going to have more devices. I think that is the future.
Yeah. So I mean that's good to know. So I think it's like just understand the technical parameters of the machine. If you're looking to invest in a machine, exactly like you said, like what are you going to use it for, and look at those technical parameters and really delve into it, because obviously it's a decent investment.
Because if you look at the electromagnetic, the electromagnetic, the size of the focal zone will be more or less constant. If we look at the electrohydraulic, then the -60B and the 5 MPa will be bigger when you increase the intensity. If we look at the piezo, when we increase the intensity on the focal point, then the main part of the -60B zone will actually be smaller, even though we have a bigger 5 MPa. So that is also something you need to be aware. But I doubt that most people will read the back end of the the manual where they actually can see the size of the focal zone when they start mixing around with the energy.
Well, they see the marketing pictures. Going, oh,
But
that's
that will go. I will go through that when we reach November.
yeah.
It's a big part of the technology presentation.
No, great. Obviously, focusing on the technology, we've had a question come in from John Ostrowski. John, I know John, we've done a webinar with him before, so it's good to see you on, John. He's asked, can you explain the necessity for the various handpieces, as his thought is that the depth of isolation with the shockwave will get there with any of the handpieces you have shown in the earlier slides. So I think he's referring to with the piezo wave, it's got 5 therapy sources, so just explaining the differences between them, really.
Normally people will have 1 or 2 handpieces. Right now I have a few more, but when I got my device in March or April, I decided to have 2. I want the linear because that was really interesting, and I wanted to have the one with the most powerful penetration, and that was only to 4 centimeters of depth. But I decided that I knew it was for superficial use. So if you want to have the high energy, then maybe you're gonna sacrifice a bit on the penetration depth. I'll say that the it must be the G6, this one.
Yeah.
This is a upper layer.
Yeah.
That will be 80% for everything. Right now, I'm also using it for components, so I sacrifice a bit on the top of the energy to get a slightly larger minus 60 dB zone. So I know it's really complex. The FG10 that I have over here, that is for the more deeper laying structures. But as I also said, most of the time we will have the structures within 2 to 4, 5, 6 centimeters when we look at the pelvic floor. So if I really want to go extremely deep, then I wanted that one. But I will say 8, 9 times out of 10, I can do it with the G6.
Yeah.
So for me, I have the luxury of borrowing a few extra handpieces to test it, to see how we can optimize. But right now, my recommendation is that the G6 is a really good trade-off compared to amount of energy, size of the focal zone, and the durability that you can get. So that is also where we come closest to the focal zone size of an electromagnetic device. Did that answer the question, John?
Yeah, and I think we'll discuss it more, I think, in the course that we do. And I mean, in terms of like from our perspective, like we predominantly focus on the FB10 G6 and G4, so the 4 centimeter and 6 centimeter, because as well as men's health, obviously they're very applicable for the musculoskeletal, which is a lot of physiotherapists will be seeing the Achilles, patellas, plantar fascias. So as a very, they're 2 very, very versatile. I mean, it's the kind of a little bit of a plug now. Obviously, I know we represent the piezo system. It's quite unique that you do have the choice, and each one's been designed for different things. I know the linear was originally for men's health. It is used in MSK, but we actually say no. If
works quite well on pain shoulders. I use it on the dog as well. So it's
and I think that's the thing. There's no perfect solution. It's like with cars, isn't there? It's that when people say this is the best versus this, it's like what metric? Because if you compare a Lamborghini versus a Ford Focus on speed, Lambo, on fuel economy, Ford Focus. So it depends on what you kind of like comparing these metrics. But certainly we'll cover some more on that another time.
And
in terms
that's also why that sometimes you just need to accept that you're gonna get 80%, and if you want to be specific, you're gonna have more. And I won't put in any names, but several people in the ISMST community, they use different devices. One I can tell is Johannes Müller. He's having the piezo, he has the MTS, works with both. There's other people doing the same. Hartmut is having everything. So it's really about figuring out what you want. And at some point also from your learning curve, you want to add something because you're gonna get more experience. My experience with Shockwave has been great so far, But after adding the other devices and starting really to read into the technology and the difference, I'm getting so much better results because I understand exactly what I'm doing and how to get the energy into the right place.
Yeah, no, absolutely. So one of the other pre-submitted questions, we've got a couple more of those. We've got a few more coming in on live as well. In terms of like, what are the biggest considerations before starting the treatment with Shockwave? So
For
in
men's
terms
health
of
in
like what,
general,
well, yeah, like neuro. So like, it's like what
you
causes
need to,
vascular ED? Is it, because there's going to be other considerations, whether there's potential cancers
in the
or
beginning, when
whatever.
you start when you start working with these kind of patients, then you need to take the easy cases, the one with the lighter degrees of erectile dysfunction. You don't gonna start with the diabetic with polyneuropathy, 5 different kinds of medication, because you're gonna crash and burn. So start easy, talk about what they want to achieve with these sessions, and what are they willing to put in for themselves. I start to say no to people where I can sense they want a quick fix. I say
Yeah.
no if they don't want to do the necessary life change. And I also have people that's failing. I had 2 guys 3 weeks ago where we failed. And when I reasoned about it again, one was diabetic, have neuropathy. He walked really, really slowly, didn't really do any exercise, lots of stress. I should have been saying no, but he said, yeah, I'm going to change something. Another guy, similar case, obesity, no physical activity, couldn't put it in, lack of sleep, high stress. When you see these guys, that's not where you start. And the more severe case you have, the higher frequencies of the sessions as well. So if it's a lighter degree, 1 session a week, maybe 2. If it's severe, 2 to 3 sessions a week, depending on the schedule. But in general, I do 1 for the lighter and 2 for the more severe per week. And then depending again on the device, it's also different how much you need. In general, 6, 9, 12, going from easy ED to severe. And with the severe, most likely some of them going to have more. We're going to discuss the pulses. That's also different from system to system. And also if you have the linear or if you have the more focal point, that will be slightly different in the protocol. Again, you need to remember how big is the focal zone. And regarding how many pulses, how much energy, is also depending on the severity. So in general, we do the same amount of pulses, but we increase the number of sessions. But for some more severe degrees, you can add maybe 20-25% on what you normally would do. We can also start talking about the penis size. If we have a very small penis, maybe we don't need to do the same amount as on a big penis. So there's a lot of factors weighing in. And you also need to look into the depth. I can see there's a question about a 5 millimeter depth suitable for ED. Again, small penis, it's okay. But in general, we want to reach about 1 to 1.5 centimeters. Then we're going to cover all the area. So again, look into the technology, look into what is the size of the focal zone. So when I do the ED treatment with the linear, I either do the 15 or the 10 millimeter standoff, because then I'll get the energy in where I want it, depending on the size of the penis and the need of the client.
Yeah. And I suppose that's, again, it's like the different, like understanding the focal zones and where your maximum energy point is as well, understanding the full height of the focal zone as well, because there's obviously the different points in it is also really important. So, I mean, there's
Yeah,
potentially.
you can't go wrong.
Say again?
If you use the linear, you basically can't go wrong if you just have the 10 millimeter standoff on, then you're gonna hit everything you want to.
Sure. Now I'm going to just try and rattle 3 or 4 questions into one, because we've had a few that I think you can just rattle them into one basically. So you've already touched on depth. Is the 5 millimeter depth suitable for ED? So we said 1 to 1.5 centimeters, but it can vary depending on the size and thickness of a penis of the person that you're dealing with. What frequency do you set on the shockwave? How do you decide the energy that you deliver for the session? And how many sessions
I
would you
basically
put for
just
course
answered that.
frequency?
I basically just answered that. Frequency
Okay,
are
great.
highest as possible, especially because you want to do a lot of pulses. I think some of the protocols is a bit conservative, so maybe increase
Yep,
it, but we go through that in November. And of course,
yep.
as I said, it's also about lifestyle. So pelvic floor exercises, if they have a weak pelvic floor, that will help on the erection. It can actually give 10 to 15% on the erectile function to do pelvic floor exercises. The other benefit is also that we, with the shockwave, stimulate the pelvic floor, the perineum. So we get this stimulate to the pudendal nerve, so they're gonna get better contact to the pelvic floor. We want to stimulate that by treating it and training it.
Excellent. So I'm going to tick off questions there. Into the just not my laptop. So let's have a quick look at the other pre-submitted questions. Got those. In terms of like main research papers and reading, we see this in the musculoskeletal world. You've covered a couple of papers there. I'm going to tie it into the question that Andre's asked as well, is that for those who will come into the 15th, and even those that are not coming to the workshop, is what would be some good research papers and literatures that you would recommend
If
delving into?
take two, I would take the study by the Greek group, where you had that very nice graph. And then I would take the study from Hartmann Post, because then you're going to have all the different devices explained down to the physics, and even for some of the devices, the prices, maintenance cost, how they work for the different indications. So that would be the two top studies I would do before. Otherwise, just read into erectile dysfunction, peyronieus, the etiology in general, pelvic pain, just so we have a general feeling about the conditions. But I promise you guys that in November, when you're gonna sit at the workshop, you're gonna see a lot of different studies. So just have the basic covered, and then you can always take pictures of the slides and these studies that's put up there. I was teaching Dawn when we had this discussion that when I do my 2-day course in Copenhagen, there's about 380 slides for these 2 days covering men's health. So we're gonna do something like 45% of that in Manchester. So you're still gonna be on around 150 to 200 slides. So you're gonna just come with a clear head. That's good.
Clear head and some coffee.
Yeah.
I mean, I suppose, and I think that's it, isn't it? I mean, fundamentally, it's like before you do anything, like understand the anatomy, and that doesn't mean necessarily for the gentleman that come into the course is to stand in front of a mirror and just have a look. I think it's really have a good look at the anatomy and get to grips with the different terminologies, like you say. What we're going to do is we're probably going to wrap up there. We've covered the vast majority of the pre-submitted questions. From that, before we kind of wrap up, Michael, are there any other sort of last comments that you'd like to make?
I normally say if you want to do men's health, do nothing else than men's health. That is like my main thing. But you just need to remember that this is something that people really care about. So you need to have the respect. You need to know what you're doing. You need to know the devices. I don't expect you to do high-end ultrasound, but then at least do the different questionnaires, so you have something that's founded in research, so you can track it and you can give some good advice and recommendations.
No, brilliant. I know we'll touch on the diagnostic ultrasound element. We will have ultrasound at the course as well. And like I say, if you don't have access to diagnostic ultrasound or can't scan, I think you mentioned it as well, is get a referral, work with somebody who can. So I think there's a few things to consider for people on today. So listen, Michael, thank you very much for your time. For everybody who's joined live, thank you very much for your time as well. Those who are watching the webinar back, you can see we've got some contact details there. If you have any questions, comments, queries that you'd like us to answer, send them in to info@physiequip.com. You can also find some more information and this will be published up onto the Academy website, so academy.physiequip.com as well, which you can find. In terms of upcoming events, we have another webinar on the 6th of November on Shockwave specifically for erectile dysfunction. So we're going to go into the application of Shockwave on erectile dysfunction in a lot more detail. And we've mentioned it a couple of times. Really excited to have you over in the UK, Michael, on the 15th of November for our course on Shockwave for men's health. Currently, we have an early bird offer, which is running until the 1st of November, 225, £225. After that, it will go to 295. It's a one-dayer, so it's something I'm really excited about. We've just heard so much feedback from physios and who are using Shockwave, others looking into Shockwave, just asking for more comprehensive education. One of the big things that we like to promote is that it's open to all. You use different technologies, Michael. We want to be able to welcome everybody in into whatever technology you've got. We want to make sure you've maximized your investment. And you know, with your experience across the different technologies, I think that's a great opportunity for people. For those interested in other further education, we launched the online Shockwave Therapy course, which again, open to all, regardless of the technology that you use. There's no exclusivity here on the education. The online course, hour and a half, 16 episodes, looking at the fundamentals of the technology. So it'll give you really, really good background. So if you don't use Shockwave yet, great course, 95 quid. Decent workbook as well. You can learn it in your own time, which is really, really good. We'll send all this information out afterwards as well. So like I said, the other things we'll send out, we'll send a survey. So any more information you'd like to know, let us know. If you want to hear from anybody else or any other subjects, let the guys at the Physio Academy know, and we'll try and put those things on. Otherwise, we shall wrap up there, Michael. Once again, thank you very much for your time. Really excited about the things moving forward around Shockwave and men's health with your expertise behind it. Again, thank you for everybody joining. We'll sign off there, Michael.
Yeah. Have a great evening. Now it's time for food and white wine.
Absolutely. Sounds great. Take care, everybody. Thank you.